Have you ever thought about what it would be like to have a fire just smoldering deep inside your lungs? Well, that's a pretty good way to picture chronic obstructive pulmonary disease, or COPD. It's something that often gets brushed off as just a smoker's cough, but the scary part is, by the time people start taking it seriously, a lot of the damage is already permanent.
And that really gets to the heart of the matter. This question is everything when it comes to COPD. You see, with a lot of other lung diseases, there's a possibility of healing. But COPD, it's all about damage that just doesn't go away. The lungs literally lose their elasticity, their ability to bounce back. So, let's get into what's actually going on in there.
All right, so let's start with that fire. We're going to dive deep and look at the core of the problem, what's happening way down in the airways, and the tiny air sacs that leads to this kind of irreversible damage.
Okay, there are a couple of really key words on this slide: persistent and progressive. This is so important because it's not like asthma, where your airways can tighten up and then open back up again. With COPD, the damage from inhaled toxins, usually cigarette smoke, but it can also be things like dust at work or heavy pollution. It causes a blockage that never totally goes away. And if you don't do anything about it, it only gets worse over time.
You know, COPD isn't just one single disease. It's really a mix of two major problems happening at the same time. On one hand, you've got chronic bronchitis. Think of this as the airway problem. It's where your breathing tubes get all inflamed and clogged up with way too much mucus. And then you have emphysema. This is the air sac problem. The tiny, delicate little balloons at the end of your airways that do all the work of gas exchange, they literally get destroyed. And the truth is, most people with COPD are dealing with a little bit of both.
The whole process is like this awful chain reaction. It all kicks off with those inhaled toxins, and that triggers this relentless chronic inflammation. Your own immune system, this army of cells, gets called in, but it ends up attacking your own lung tissue, just destroying it and gumming up the works with mucus. And the end result of all that damage? The airways lose their structure. They get floppy, and they collapse when you try to breathe out. This traps old, stale air inside, which makes it feel almost impossible to get a good, deep, fresh breath of air in.
So, that's what's going on deep inside. But how does all that internal damage start to show up on the outside? Let's take a look at how this disease progresses from what seems like a simple little cough into a full-blown crisis. You'll see the early signs are really subtle, but they are critical warnings.
And here's the classic and kinda sneaky timeline for how COPD often plays out. For years, someone might just write off a morning cough as, "Oh, that's just my smoker's cough," or think they're just getting out of shape when they get winded going up a flight of stairs. The real tragedy here is that by the time these symptoms get so bad that you just can't ignore them anymore, the disease is usually already pretty far along.
You can kind of visualize the two extremes of this disease with these classic old-school profiles. On one side, you have the pink puffer, which is where emphysema is the biggest problem. These folks are often very thin because it takes an incredible amount of energy and work just to breathe. Then on the other side, you've got the blue bloater, where chronic bronchitis is the main issue. They really struggle with low oxygen levels, which can actually give their skin a bluish tint, and they have that constant, nagging, mucusy cough. Of course, in the real world, most people fall somewhere in the middle, a mix of both.
Okay, so with such a wide range of symptoms, how do doctors get to the unmistakable proof? Let's dig into how they actually confirm that yes, this is COPD.
And this is the million-dollar question, isn't it? I mean, both conditions can make you wheeze and feel short of breath, but the test for COPD is looking for something very, very specific that really sets it apart from everything else. And believe it or not, it all comes down to this one number. This number comes from a breathing test called spirometry. Here's a way to think about it. Imagine your lungs are a full bucket of water. The test measures how much of that water you can splash out in the very first second. Now, a healthy person can force out most of it right away. But someone with an obstruction, with a blockage, just can't. So if you can't exhale at least 70% of the air from your lungs in that first second, even after taking a puff from an inhaler to open things up, that tells us there's a permanent blockage. That right there, that is the definitive proof of COPD. So once the diagnosis is official, doctors then categorize the disease in two different ways. First, you have the GOLD grades. These basically measure how bad the airflow blockage is, and that helps predict the long-term outlook, the prognosis. But then you have the GOLD groups, and these are what really guide the treatment right now. They focus on how a person is feeling day to day, their symptoms, and their history of flare-ups to build a treatment plan that's right for them. So once the diagnosis is set and the patient is categorized, the whole focus shifts to treatment. It's time to fight for every breath.
Let's look at the strategies doctors use to manage the symptoms and really help people breathe easier. The initial treatment plan is really a step-by-step approach based on those gold groups we just talked about. So for someone in Group A with pretty low symptoms, you start simple, with one type of long-acting inhaler to help open up the airways. If symptoms are more of a problem, like in Group B, then you use two different kinds of inhalers together. And for those in Group E, the high-risk folks, you start with that powerful two-inhaler therapy right out of the gate.
But treatment isn't a one-and-done kind of thing. It's always being tweaked based on what the main problem is. So if someone is still really struggling with shortness of breath, what doctors call dyspnea, the next move is to ramp up the medications that open the airways, the bronchodilators. But if the bigger issue is those frequent flare-ups or exacerbations, then the strategy changes. And in that case, doctors will actually look at a blood test at the level of a specific inflammatory cell called an eosinophil to decide what the next best step is.
And this is where we see a huge difference between treating asthma and treating COPD. In asthma, steroid inhalers are like the cornerstone of treatment, but in COPD, they're used way more cautiously. They're really reserved for those patients who have a lot of flare-ups and have those high eosinophil counts we just mentioned. And the main reason for that caution? They can actually increase the risk of getting pneumonia. It's an absolutely critical difference to understand. Now, we've talked about a lot of different treatments and medications, but among all of them, there are two interventions that just stand head and shoulders above the rest. And that's because they don't just help with symptoms, they are the only two things proven to actually help people with COPD live longer. I mean, just let that sink in for a second. No pill, no inhaler, no special therapy can do what this one single action does. It is, without a doubt, the single most important thing anyone with COPD can do. And here is exactly why. Quitting smoking can't turn back the clock and undo the damage that's been done. But what it can do is stop the bleeding, so to speak. That steep, scary decline in lung function that we see in active smokers, it just stops. It flattens out. It completely and fundamentally changes the entire course of the disease.
So smoking cessation is number one. What about the second lifeline? What's the only other thing that has been proven time and time again to extend life for people with severe COPD? The answer is 15 hours. For patients who have very severe COPD, using supplemental oxygen for at least 15 hours every single day has been proven to help them live longer.
Now, this isn't for every single person with COPD. It's specifically for those whose blood oxygen levels consistently drop to 88% or even lower. See, when your oxygen is that low, it puts an enormous strain on your heart and all of your other organs. So, by providing that supplemental oxygen for most of the day, you relieve that strain, and that is why it ultimately helps patients live longer. Look, COPD is a really devastating disease, and as we've seen, the damage is permanent. We have treatments that can help manage it, but we can't reverse it. And that brings us to the biggest, most important question of all. Knowing that this fire inside the lungs is almost entirely preventable, what's it going to take for us to finally stop lighting the match in the first place?